So given Craig's level of injury, these are some things that we would like to assess. So a clinical observation of his head trunk control, oral motor control, and endurance. And for his physical status, looking at his respiration and his skin integrity, assessing for spinal shock, pain, temperature regulation, as well as spasticity. And then for sensation, looking at light touch, deep pressure and kinesthesia, and if it's absent, impaired, or intact. He is a C6 complete, and so looking at which muscles are innervated will be discussed below. But then we're also going to look at passive range of motion, specifically for shoulder flexion, elbow flexion, and palmar supination, because we want to evaluate for potential joint contractures. And then in C4 through C7 quadriplegia, shoulder pain is common, which is why we want to do passive range of motion rather than active range of motion. And then once you do passive range of motion, then you can do manual muscle testing only after spinal shock subsides, because then tone may increase after this passes. C5 level, the muscles that are innervated typically are the deltoid, the biceps, brachialis, brachioradialis, rhomboids, and serratus anterior, which is partially innervated. So the movements that are possible are listed here. Non-innervated muscles, so these would be the patterns of weakness. So that would be the absence of all elbow extension, pronation, wrist, hand movement, and total paralysis of the trunk as well as his lower extremities. So some medical emergencies that can be life-threatening in spinal cord injury are autonomic dysreflexia. So this is an injury at the T6 level or above, and then can result in high blood pressure due to a noxious stimuli. And then the signs and symptoms of this are pounding headache, profuse sweating, flushed skin, goosebumps, trouble breathing, anxiety, a stuffy nose, blurred vision, and chest tightness. And it's important to note this because it can lead to stroke or sudden death. And so if this occurs, then stop whatever activity you're doing, check their blood pressure, and if it's high, make sure that you have the person sit up, loosen anything that is constrictive on their body, and check their urinary catheter for any folds and straighten them, and then monitor their blood pressure and seek medical assistance if it remains high. The opposite of that is orthostatic hypotension, which can also occur in spinal cord injury patients. And so this is whenever blood pressure drops to dangerous levels, which are really low, and can cause the individual to actually lose consciousness. And so signs and symptoms are lightheadedness, pallor, and changes in vision. And so if this occurs, then stop the activity and check their blood pressure, but recline the individual in either their bed or wheelchair, and then monitor their blood pressure and seek medical assistance if it remains low. Something else that is very important to instruct Craig in is pressure relief. And this can be done in the power chair using the tilt and recline method. And so education for the family and for Craig is important because if he is in the wheelchair, then we want him to weight shift for at least 2 minutes every 30 minutes. And then if he's in bed, we want to reposition him every 2 hours. And so skin breakdown occurs if pressure relief is not the schedule is not adhered to, and so you have to make sure that we educate the family as well as Craig to inspect his skin daily. So because Craig is a C5 complete injury, he will have flaccid paralysis, and so things that we can do in terms of intervention is positioning in bed. And so on here you can see some pictures of how foam or pillows can be used to help prevent joint contractures. And side lying is actually the best position to help manage spasticity. So that would be the best position to put him in. And then we can also use pictures to help the nurses and family members to see exactly how he needs to be positioned. And then orthotics can also be used. This will be touched on later. And then because the injury's complete spasticity can develop, and so this can lead to decreased range of motion and contractures. And so passive stretching and orthotic wear can be used to manage this. But if spasticity is very, very severe, then Botox injections can be used in conjunction with passive stretching and orthotics. So in terms of orthotics, the resting hand orthotic would probably be best for Craig because the purpose of this is to maintain the hand in a functional or anti-deformity position. And so there's a picture of what it looks like. And so for the wearing schedule, there were several discrepancies in terms of what is beneficial for the literature on the resting hand orthotic. And so we would start by wearing it for 20 minutes, and there would be one that's fabricated for the left upper extremity and right upper extremity, and just checking for any redness. And then we'd gradually increment it by starting at 2 hours a day and then increase an hour a day. And then, of course, we would label these right upper extremity and left upper extremity, so that way we could make sure that each orthotic is going on the correct limb. And then making sure to assess for redness or discoloration, and that the splint and the skin are dry before donning, and making sure we can also attach a universal cuff to the orthotic, so that way whenever it stabilizes his wrist whenever he's performing any of his ADLs or IADLs. Sitting tolerance. It's important to have a sitting schedule because medical complications like DVT, joint contractures, and deconditioning can occur from prolonged bed rest. And it's important to have them start sitting up because spasticity can also vary throughout the day. So kind of like what we had for the orthotic, we'll gradually increase time spent sitting up and build up his tolerance. And so we'd start sitting up in bed for about 10 minutes at a 45-degree angle. We could use the bed to convert into a chair so that way we could just reposition him in a sitting position. And then in case if he's not feeling well, then we can always just put him back down. And then for OT and PT collaboration for the intervention, we can work on these three things. So the first would be transfers. So there is a quad or dependent transfer, a 1 and 2 person or 1 and 2 person dependent sliding board transfer, and then we could also educate on how to use a mechanical lift. And then another intervention would be wheelchair fitting. So we could recommend a power chair and ask for permission to take measurements to get a power chair for Mr. Craig. One that best offers him like the most independence and works for his needs. And so we could also try to bring in a prototype so that way he can see the different kinds of that way he can see the type of capabilities he's able to perform in the wheelchair. And then mobility training, so we can show him how to use the joystick on the power chair and how to maneuver in and out of rooms and the hallways and the bathroom, and then of course educate the family and the client on this as well. In terms of psychological adjustments, there are 5 stages of grief, and they are not linear. So initially, since he is in acute care, I think Mr. Fig would be going through grief, and he would just be dealing with coping with his loss and the uncertainty of his future and the possibility of him having a family. However, there are some coping mechanisms that might exhibit themselves whenever he's in acute care, such as avoidance, isolating himself, or maybe having outbursts. However, he does have good family supports with his wife and parents, and as well as his in-laws, and he has a sister that lives nearby, and so they can offer their support and encouragement to him during this time.